I think we are going to discuss a topic on hypertension, which is very important in the family practice, the general practice and the family practice. And I would like to go through mainly the guidelines. There are European Society of Cardiology and European Society of Hypertension guidelines, and bit from the NICE guidelines UK, just to be very professional. And last year, the European Society of Hypertension, the conference mainly discussed the few points. And I'm not going to the basics here because I know that you all are not ordinary doctors, and you know that maybe the family physicians, maybe the more or less consultant level. So basically, what they mentioned about this out of office blood pressure measurements, like out of office means not in the clinic. Office means they are the clinic. Basically, ambulatory blood pressure monitoring and the home blood pressure monitoring by the patient. Then reconsideration the cardiovascular risk factors associated with hypertension due to overweight and the BMI, etc. Then hypertension, the old and the old. Sorry for this term, but that is the term used by them. Old means between 65 to 80 years, and old is more than 80. And even my father belongs to the old category. He's 83 years, but I don't feel him that he's old, and I feel that he's still young. But that is the terminology given that in the meeting. Then identification of the unified target systolic blood pressure level. So what they thought, the target systolic blood pressure should be 140. And the people with high normal blood pressure, that is between 120 and 140, not to treat and just to modify the lifestyle. And usually we are used to start medicine in hypertension with single drug. And what they said, there is a role for starting two drugs simultaneously. So again, it's a new concept. And special attention to resistant hypertension. We get lots of patients who are not respond to our regular treatment. When it comes to the definition, the optimal, sorry about this 180, optimal blood pressure should be 120 by 180, this is a mistake. And normal blood pressure could go to systolic 120 to 130 and diastolic 80 to 84. High normal means systolic between 130 and 140 and the diastolic between 85, 90. They thought that they are a category not to start any pharmacological treatment, this high normal category, just to modify with the lifestyle. Then grade 1 hypertension means between 140 and 160, and the diastole between 90 and 100, where we have to start medicine. But they thought in grade 1 hypertension, it's better to, if we have to consider with other cardiovascular risk factors, which I am going to touch briefly, start medicine probably with a single medicine. Grade 2 hypertension means systolic between 106 to 80 and diastolic between 100 and 110. In that category, we may have to consider dual starting two drugs, or still we could try with lifestyle modification and a single drug. Grade 3 hypertension means systolic blood pressure more than 180 and the diastolic is 110. At that category, the decision was we can start two different classes of antihypertensives simultaneously. Then they discuss about this, the isolated systolic hypertension, which is common in elderly due to arterial stiffness, where the systolic blood pressure is more than 140 and the diastolic is less than 90. So basically the same. The types are, I just touched those things. We know that when it comes to the hypertension, there are two major types, primary or essential hypertension and secondary hypertension, where we may be able to find a cause. In addition to those things, we get malignant hypertension, isolated systolic hypertension, white coat hypertension, and resistant hypertension, which are kind of important topics again. And secondary hypertension, we all know there are possible causes. It could be commonly renal causes, maybe polycystic disease, maybe acute glomerulonephritis, maybe diabetic associated renal disease. Secondary hypertension could be due to endocrine causes like well-known pheochromocytoma, Cushing's, Cons, acromegaly, or thyroid hypothyroidism. It could be due to vascular causes, coarctation of aorta and conditions like renal artery stenosis. Though those conditions are rare, when it comes to the, you guys are the people who get the patient first. So it is important and to go consider those secondary causes whenever you get a patient with hypertension, especially when somebody comes with stage 2 or stage 3 hypertension. And then you get high blood pressure with pregnancy-related conditions, in connective tissue disorders like SLE, and sleep apnea syndrome. People come in with obstructive sleep apnea. It's very common, and we see lots of patients and they come with high blood pressure. Then you get high blood pressure with pregnancy-related conditions, in connective tissue disorders like SLE, and sleep apnea syndrome. People come in with obstructive sleep apnea. It's very common, and we see lots of patients and they come with high blood pressure. And sometimes it could be related to various type of medication or alcohol and drinks, etc. Isolated systolic hypertension is again a common area where you meet more than us, that when it comes to the family practice, systolic blood pressure more than maybe consistently above 140 or sometimes it came as 160, but the diastolic is importantly, systolic blood pressure more than 160 and diastolic 100 less than 90 is not a lot. So people might request you not to treat those conditions, but it's important to treat those conditions, but because it's associated with stroke and heart diseases. And always we start with the lifestyle modification, and if necessary, we go for the drugs. And these are the common factors for hypertension we see in our day-to-day practice, the excess body weight, and we see lots of obesity nowadays, even among the children. And we eat lots of sodium. And if you eat on Sunday with the kiribat and lunumiris, maybe a kolakanda, and it is a lots of salt. Salt, by definition, is a kind of a poison to the high blood pressure. But we Sri Lankans and we Asians, we eat lots of salt. That's a classic example is the kiribat and the lunumiris and kanda, the favorite kanda, contains lots of salt, and it's an important area where we have to touch. And reduce physical activity. And we don't eat fruits and vegetables. But we'll take this opportunity that in Sri Lankan setup, if you eat lots of fruits, and it might push the blood glucose up. Most of our fruits are very sweet, like mangoes. I advise them not to eat lots of overripe fruits, then the alcohol. And when we get the patient, first thing is the evaluation. And we don't take one blood pressure measurement, we take 2 consecutive measurements. Then we we go through their lifestyle and go through their other cardiovascular risk factors, maybe in addition to the hypertension, maybe ischemic heart disease, diabetes, hypercholesterol, and then we consider those things. And we try to identify cause for high blood pressure, whether it's obesity, whether it's high salt, no exercise, maybe alcohol, or maybe some other medication like steroid while the patient is on. And then we try to assess any presence of absence of any target organ damage, like whether the patient has got a high creatinine level, or whether the patient has got ischemic heart disease, or patient has got retinal changes due to diabetes. So this is basically the same. Not only the blood pressure, we go for other cardiovascular risk factors, and we look for diabetes, look for renal functions, and depending on the risk factors, we consider them whether to moderate, high or very high risk of category. Diabetes or CKD stage 3, it's not very uncommon. You get CKD stage 3 means the estimated GFR less than 60. Most of the people belong to that category. And we then categorize them as in the very high risk. It's basically the same. And when we get the patient with hypertension, there are other factors also contribute to the ischemic heart disease. Maybe obesity, especially the abdominal obesity, which is very common in our country. And we think it's something to be proud of, which is not, and it's a kind of a sign of ill health. And And the abnormal glucose tolerance test may be the fasting blood sugar between 100 and 126, may be the impaired fasting glycemia. And somebody in the male sex, ankle brachial index, that indicate poor circulation. And past history of MI, ischemic heart disease, and renal impairment, etc. And if we happen to do a ECG, if there's evidence of LVH, and when we do a echo, and we commonly get the reports saying that this patient good normal valves, very good LV function, and so we tend to ignore those things. That the good LV function, good normal valves, normal echo, but the cardiologist mentioned the left ventricular hypertrophy, and we have to consider those things because these could affect them adversely. And the other thing is whether there's a family history of premature cardio. I know that you are doing all these things, but for the sake of completion of the thing, I'm going through this thing. And the bit of high blood glucose level, fasting blood sugar between 106 to 126 is an important area. And smoking and symptomatic lower extremity peripheral vascular disease. It's basically the same thing, but we are supposed to do 2 readings, 5 minutes apart, the blood pressure, sitting on a chair, and it should be in the same level of the heart. And if the patient is a diabetic or elderly one, we have to see whether there's any postural drop. It is a must. And we have to educate about the self-measurement, measurement of the blood pressure at home. And it will improve the adherence to the therapy, and it gives a good compliance of the patient. But most of the problem in our country, most of the machines are not 100% accurate. So it might give a false alarm. So, that we have to make sure that the home blood pressure apparatus is a good one. It's basically the same, the cuff level at the home, and we use the phase 1 and 5. First visit, if we find the blood pressure is high, we have to measure the blood pressure in both halves and 3 to 5 minutes apart. Elderly people and diabetic, we have to see whether there's any postural drop. And we have to measure the heart. If we find that the patient is in high blood pressure, we have to measure the heart rate by pulse palpation. Out of office blood pressure, they talk a lot about out of office blood pressure. That means self-monitoring, maybe ambulatory blood pressure monitoring machine, which is, we get lots of patients, maybe that they come to the doctor, blood pressure could be falsely high, probably due to white coat effect, maybe they are a bit of under stress, so better to do a 24-hour ambulatory blood pressure monitoring before starting treatment. Most of the time, once we start the treatment, it is a lifetime business. And when you do the ambulatory blood pressure monitoring, daytime or waking time blood pressure average should be more than 135 to 85. Night time it should be more than 120 to 70 average to label them as hypertensives. And the average blood pressure, if 24 hours more than 130 by 80, then we have to consider them to start managing as hypertensive patient. Home blood pressure usually little less than the office blood pressure. When we check the blood pressure at home, it could be what they say the blood pressure, if the the clinic blood pressure is 140 systolic, the home it is 135. When the diastolic is more than 90 in the clinic, the home it could be little less than maybe little 85. Then ABPM is the ambulatory blood pressure monitoring, and the HBPM is home blood pressure monitoring. And we always suppose, when the patient comes and we think the blood pressure is high, then we have to take a detailed history and regarding the duration and the previous values of the blood pressure, any symptoms and signs of secondary hypertension like pheochromocytoma, you get palpitation, sweating, panic attack, and familial renal diseases like polycystic disease, etc. Then a past history of hematuria, maybe patient had a past history of nephritic syndrome, and whether the patient had analgesic abuse. We see this analgesic abuse very commonly, and lots of elderly people used to get some kind of a painkiller, maybe strong painkillers, and the oral contraceptives, steroids. some people self-use steroid and NSAIDs, and features of pheochromocytoma and muscle weakness there, which you get in the high aldosterone level, smoking, obesity, and whether there's any evidence of organ damage, maybe tiny strokes, whether ischemic heart disease, heart failure, hematuria, and the evidence of peripheral vascular disease. Examination, yes, we do all these things, and just to mention those things, and we have to look for the signs of hypertension, maybe coarctation of aorta, maybe a renal artery stenosis to see whether there's any murmur, and whether we have to do a good abdominal examination. Unfortunately, those things are not happening now. We see lots of patients, even after going to the hospital and coming back, abdomen was not examined. Value of the physical signs are still same, that even the good old days, and now there's no difference, and we have to do a proper examination. And if the patient is having high blood pressure, then we have to look for the evidence of brain involvement, maybe a sensory or motor deficit with a tiny TIO stroke-like thing. Fundal examination to see whether there's any hemorrhages or exudate, and cardiovascular system to see whether there's any murmurs, arrhythmia, or evidence of heart failure. And we have to pay a big attention to the obesity. Routine lab investigations is basically what we do. Start from the full blood count, blood sugar, cholesterol, uric acid, renal functions, maybe urine for microscopy and ECG, and probably ultrasound scan if the patient is young, and that if you need, it's necessary. In additionally, if the blood pressure is little high, and we may have to think about other conditions, associated conditions like diabetes. If the patient is having proteinuria, we may have to quantify it by doing 24-hour urinary albumin extraction. And if we are suspicious about this blood pressure value, we can do a ambulatory blood pressure monitoring for 24 hours and can assess the heart function. And to see whether there's any LVH, we can do an echocardiogram. If you have a doubt about the blood pressure, and if you do echo, and if the patient has LVH, that means definitely the patient has established hypertension for some time. And in Holter monitoring, if you feel that there's a evidence of arrhythmia, carotid ultrasound just to see whether there's any thickening or intimal thickening, and abdominal scan, and maybe the fundoscopy, etc. And we should not forget, though it is rare, the secondary hypertension is still possible. And always we have to think about the primary aldosteronism, renal artery stenosis, and renal parenchymal disease. These are not uncommon. And Cushing's, by looking at pheochromocytoma, history might give a clue. And when you get a patient, secondary form of hypertension, we have to suspect. If the patient has very high blood pressure elevated, maybe 100 grade 3 class hypertension, or sudden onset worsening of hypertension. Somebody has normal blood pressure, control over a period, and suddenly it's getting worse. And we are giving maybe 2 drugs or 3 drugs, but the blood pressure response, the blood pressure control is poor. So there may be some reason. Or other things, some organ damage, maybe a renal damage, disproportionate to the duration or the degree of hypertension. That means the patient is a very short duration of hypertension, or mild degree of hypertension, but there is a organ damage. Then we have to think about whether there's something underlying in the body. Treatment goals, I told you that the systolic blood pressure is 104, less than 140. And but in a patient with diabetes, we tend to go, diabetes and CKD, systolic blood pressure, we tend to go little less than 140. We are targeting a systolic blood pressure 130. But other conditions like past history of TIA, maybe a stroke, ischemic heart disease, those conditions, still we could go for systolic blood pressure 140, which is a very safe limit. Elderly hypertensives, that means less than 80, with systolic blood pressure more than 140, we should intervene, maybe only with lifestyle modification. The goal is to keep it less than 140. In that old category, that means more than 80 years, having a systolic blood pressure more than 60, we should intervene, and we have to think about the systolic blood pressure somewhere around 150, and we should not reduce it to too low. And diastolic blood pressure less than 90 is the target for normal people, but with diabetes and CKD patients, we have to think about little less than 80. So basically, in hypertension, the universal target is less than 140/90. But if we have diabetes and renal disease, we may consider 130/80. Again, this figure is a bit of a doubt whether we are going for 140/90 or whether we are targeting a little bit of a low value. We start with lifestyle modification, then we think about pharmacological treatment. Initial therapy may be a single drug or may be a combination. And if then we review the patient, then we see whether the patient has got we have achieved the target, the goal which we are talking about. If not, we'll think why it's not happening and follow up and the monitoring. Basically, this is the algorithm. We start with the lifestyle and follow up them. And the stage 1, that is the blood pressure is between 140/60 and diastolic blood pressure 90 to 100. We start with usually with the single medicine. Commonly, what they mention is the thiazide type of diuretic. They talk about indapamide and or HCT class. And then think about ACE inhibitors or angiotensin receptor blockers or calcium channel blockers. What they say, if the patient is more than 60 years, go for a calcium channel blocker, and less than 60, think about ACE inhibitor or angiotensin receptor blocker if you are considering a single drug. Then if the patient is in the stage 2, then if that means systolic blood pressure more than 160 and diastolic more than 100, straight away we can go for 2 drugs, maybe 2 drugs separately, like ACE inhibitor or thiazide group of diuretics. Nowadays we get combinations, also combination of medicine that is allowed in our country. Then if it's not settling, then we have to think about advancing the medicine. Starting with lifestyle, alcohol has to be restricted. We can't advise them to stop it completely, and what they say, alcohol in moderation may be some benefit. Sodium restriction and proper dietary modification may be the fat and the saturated fat and those things, and weight loss and exercise and the stress. Most of the people, young people who work in the kind of banks, maybe in private sector, they are going through a big stress because they are working, and night they are studying and doing some exams. So we have to address those things, and the smoking has to be stopped if the patient has high blood pressure. Well, we can get a kind of fair amount of blood pressure reduction with weight reduction, good eating plan. Well, I'll come to this DASH eating plan. Dietary sodium reduction. If you go through our the meal, day-to-day meal, we eat lots and lots of salt, and the physical activity and moderation of alcohol. DASH stands for dietary approach to stop hypertension. It definitely helpful to lower the systolic blood pressure. It consists of low in saturated fat and cholesterol, and emphasize the fruits and vegetables. In Sri Lanka, it's not very difficult. We can have a very colorful meal. We have lots of vegetables, green leaves, and fruits. It's not like Europe. We can have a very colorful meal, and reduce red meat, sweets, and sugar-containing beverages, and needs potassium, calcium, protein, basically fruits. Sodium has to be restricted, and we can reduce the blood pressure. When we give you this kind of diet plan, it takes maybe 1 or 2 weeks to act. It will not happen. The blood pressure reduction will not happen in 3 days' time. Pharmacological intervention, I'll come to details. Basically, there are 5 classes, mainly thiazides, calcium antagonists, ACE inhibitors and ARBs, beta blockers, or are they alone or in combination. And fixed combination therapy indicated in majority of hypertensive. Sometimes I told you that receptor blocker can be combined with diuretics. Even this, losartan is combined with HCT. It's available in the market. The sponsors, they have valsartan, which is combined with the HCT. It's in the market. So fixed combination therapy, we encourage it in the license in Sri Lanka. Monotherapy, initial treatment in cases of mild hypertension, but combination of drugs can be started in grade 2 or grade 3, the kind of high blood pressure. And most of the time we combine angiotensin system, the 2 drugs, that is the ACE inhibitors and the receptor blockers. We are not supposed to do it now. We have to use either ACE inhibitor or ARB. ARB is receptor blocker or sartans, with either diuretic or with calcium antagonist, and we are not supposed to combine these 2. We see lots of prescription combining those 2. And blood pressure is mainly the most of the drugs go through this system. When there's a fall in blood pressure, we know that there's a release of renin, then angiotensinogen, angiotensin 1 convert to angiotensin 2. Angiotensin 2 is a very powerful chemical, and it causes lots of vasoconstriction. And the mechanism is we have new drugs to block the effect of renin inhibitors, aliskiren, is coming to the market. Then angiotensin 1 to angiotensin 2 inhibitors, ACE inhibitors. Then angiotensin 2 receptor antagonists, all the sartans, losartan, valsartan, all these sartans. Then aldosterone antagonists like spironolactone. So this area, most of the drugs act in this area to control the blood pressure. Well, these are the complications, and we went through it: blood strokes, hypertensive encephalopathy, blood sugar, MI, heart failure, hypertensive retinopathy with hemorrhage and exudate, and then the CKD. Sorry, the slide is not very clear. When we start a medicine, then when we are going to start a medicine, we have to see whether there's any special condition. That if the patient has hypertension plus some other thing, maybe hypertension with the LVH in the echo, then we have to think about ACE inhibitors or angiotensin receptor blockers or calcium antagonists, because it helps to reduce the muscle mass. Then atherosclerosis, maybe the vasodilator like calcium antagonists. ACE inhibitors also act with vasodilatation, because I told you that the angiotensin 2 is a very powerful vasoconstrictor. So mechanism of action of ACE inhibitor is to reduce the angiotensin 2 level and have a kind of a peripheral vasodilatation plus many other effects. If somebody is having the hypertension and microalbuminuria, then ACE inhibitor or ARB. Then renal function deterioration, then again ACE inhibitor or ARB. So we have to get our choice depending on the other conditions. If somebody is having a previous stroke or angina, then we think about angina patient. Usually we don't start beta blockers as the first line unless there is some indication like ischemic heart disease or previous MI or atrial fibrillation. Then again we consider about ARBs, ACE inhibitors, and peripheral vascular disease. Usually we don't give beta blockers in patients with PVD, but again it's a controversial area. But we prefer peripheral vasodilators like calcium channel blockers and ACE inhibitors. So again, when we think about if somebody is coming with hypertension and some other indication, maybe heart failure. So if somebody comes with heart failure, always we tend to give a diuretic first. But they say if they had heart failure, you give a diuretic and make him dry. Get rid of the peripheral edema, he might get a symptomatic benefit and the crackers will disappear. Then we think about either ACE inhibitor or beta blocker. you start with the diuretic, then go for ACE inhibitor, go on for beta blocker, then think about the other medicine. MI, yes, post MI, then beta blocker or ACE inhibitor, then coronary disease, then thiazide, beta blocker, ACE inhibitor, those things. And there are diabetes. When somebody comes with diabetes, always think about ACE inhibitor or receptor blocker like losartan, valsartan, candesartan, whatever. And chronic disease, again ACE inhibitor plus a receptor blocker. Recurrent stroke prevention, diuretic and ACE inhibitor. And there are other contraindications. If somebody comes with hypertension and gout, then we don't give a thiazide diuretic. We tend to avoid it because gout could get worse. And if somebody comes with the hypertension, asthma, beta blocker. Now nowadays we have grade 1 beta blockers. It blocks the beta 1 heart and the lungs, so they could asthma could get worse. But second generation and the third generation beta blockers, the effect on the lungs is minimum. Still, if somebody is having a bad asthma, it's better to avoid the beta blocker because there are so many other types of medication. And calcium antagonist like verapamil or diltiazem, if somebody comes and start AV block, we don't give those things. And ACE inhibitors, if somebody comes with a pregnancy or possible pregnancy or somebody who could become pregnant, better to avoid those medicine, and we can give calcium channel blocker. And people with history of angioneuritic edema, we tend to avoid ACE inhibitors. Receptor blockers may be the basically same indication. So basically the diuretics, we see thiazide now. Thiazide is internationally, we don't see in lots of literature, but it comes as connected to another medicine. Thiazide usual dose is 12.5 to 25 milligrams. It comes with losartan, HCT 12.5, and valsartan, HCT 12.5 with the brand Diovan, like that. And metolazone is a very powerful diuretic. Be careful. People can go to hyponatremia with metolazone, and then we get loop diuretics. We don't start loop diuretics straight away. The indication is either heart failure. There's a place if somebody comes with hypertension and the creatinine if is more than 1.5 with the peripheral edema, then we can start a small dose of furosemide. And the other practical thing is, our people, they are used to very high salt intake. Suddenly they come with maybe heart failure, hypertension with peripheral edema, then we advise them stop salt or reduce salt, and on top of that we give a HCT. On top of that we start a sartan, a receptor blocker like maybe valsartan, maybe or losartan, maybe candesartan. That combination might give a hyponatremia, severe hyponatremia. That you may be seeing more than us. People who are given as soon as they come with hypertension, maybe a bit of heart failure, maybe elderly one who have been taking lots of salt for many, many years, and we advise, so stop salt, and then the children, they don't give salt at all. And we start HCT, maybe we start receptor blocker. That combination can cause severe hyponatremia, which can give a lethal implication. Vasodilators maybe basically most of the time is blocking the angiotensin 2. Angiotensin 2, I told you, it's very powerful vasoconstrictor. It has so many other mechanisms as well. And ACE inhibitors, angiotensin receptor blockers, peripherally acting calcium channel blockers like nifedipine, amlodipine, they act as vasodilators. And there are lots of other vasodilators in the market, and renin inhibitor, aliskiring also going to come to the market. The cardio inhibitor drugs are basically the beta blockers and rate limiting calcium channel blockers like verapamil and diltiazem. Thiazides, HCT, clothalidone is not for us, and they the market, the other thing, indapamide, 1.5 milligrams slow release once a day, or indapamide normal, 2.5 means once a day. And amlodipine and nifedipine, be careful, it's a very good drug. And it's a long-acting calcium channel blocker, which acts peripherally. So most of the time, the essential hypertension is due to vasoconstriction. As soon as we give amlodipine or nifedipine or felodipine, blood pressure calms down. Only thing, they could end up with they could have a headache. So better to advise them in advance that you might get a headache, which will disappear in 2-3 days time. Then the compliance will be very good. Another thing that at some point, these peripheral acting vasodilators, because of this vasodilatation, they could get peripheral edema. So make them aware in advance, otherwise they might lose the confidence about the doctor and he might go to somebody else saying that, my legs, feet are swollen due to this medicine and it is a poison or something like that. So give a kind of advanced warning. It's a very good antihypertensive in the absence of cardiac, other cardiac problems. Then angiotensin converting ACE inhibitors are again basically mainly vasodilatation, and angiotensin ACE inhibitors can increase the angiotensin converting enzyme needs to reduce the bradykinin level in the body. When you give ACE inhibitor, bradykinin level will go up. That can give rise a cough. So if you give a kind of a good ACE inhibitor, maybe original, definitely patient is going to end up with a cough at some point, because it's a original medicine and it reduces the blood pressure, but it will do the other job as well. It will increase the bradykinin level because it's a perfect medicine, and patient will come and with cough and tell him not to get panic, and unless the cough is very severe and disturbing his sleep and day-to-day life, to continue it. If not, we could change it. And there are lots of ACE inhibitors are in the market. There are so advantages and disadvantages of various medicine, various type of maybe captopril, enalapril, lisinopril, ramipril, all kind of things. And there are lots of trials to show the advantage of one drug over the other one. But basically it is one group. If you go to the NICE guideline, it's in UK, there are the practices, it's the government, there's no private kind of improved private sector in UK, but they say you go for ACE inhibitor. If the patient can't tolerate it, go for an angiotensin receptor blocker, which is the cheapest in the market. So likewise, but here it's not the private sector. Personally, we have to think about the budget of the patient. If the patient could afford, the original is always better than the kind of a substitute, because we are not sure about the quality. Then the angiotensin receptor blockers, that is the ARBs or sartans. Then again, there are lots of brands: candesartan, irbesartan, losartan, telmisartan, valsartan, Dioman. Our sponsors are in that group. So basically, it may be the same kind of indication. And then cardio inhibitory drugs, the beta blockers. Initially, we had the first generation beta blockers like propranolol, where they get lots. We can't give if the patient is having asthma. Then we got the second generation. Atenolol may or may belongs to the first generation, but they categorize it in the second generation drug, and there are bisoprolol and metoprolol. Then when it comes to the third generation beta blockers, they have an additional effect on vasodilatation, like labetalol, carvedilol, and nebivolol. Basically, it reduces it's mainly in the heart, and it reduces the contractility, and it reduces the relaxation rate, it reduces the heart rate, and it's mainly focused in the heart, apart from the third generation beta blockers, which has some kind of a vasodilator effect. And this is veins. Thiazide diuretics act on veins and try to get rid of some fluid. Beta blockers, calcium channel blockers, and they act on heart. And dihydropyridines means amlodipine and felodipine and nifedipine, hydralazine, and that group affect on the arteries. Surprisingly, they don't talk a lot about alpha-1 blockers. Locally we use lots of alpha blockers, but when it comes to the international guidelines, the place is little low. Then the alpha-2 agonist, basically the central acting drugs, and here we use the methyl dopa, is commonly used in the pregnancy. And you guys get the patient, when patient having high blood pressure during the pregnancy, we tend to give treat them with methyl dopa, and that after the delivery we tend to continue this antihypertensives maybe another 1 or 2 months. And if the blood pressure is persisting after more than 3 months after the delivery, we categorize them as chronic hypertension. The message what I want to tell you, that if somebody comes with after the delivery and if the patient is on methyl dopa, try to stop it and convert to a different drug, because methyl dopa can cause bit of a depression in long term. Rarely, after the pregnancy there are other depressive things are going on, like postpartum psychosis and maternal blues, etc. So if it happened to come to you, and change the medicine, because there are lots of other medicine. And calcium channel blockers, amlodipine, felodipine, we discussed those things. Very good antihypertensive drugs, but there will not be any additional benefit on heart, like it's only control the blood pressure, that's all. But make them aware of the side effects. Hydralazine, we don't give very commonly now. There was a place for IV hydralazine in pregnancy and eclampsia. Now it is again a bit of a controversial, but it is in the market, it's resistant hypertension, and if you are struggling with 2, 3 or 4 antihypertensive drugs, there's a place for hydralazine. And in heart failure, if the patient's ACE inhibitors are contraindicated, maybe patient can't tolerate, there is a place for hydralazine, but we don't use it very commonly now. And alpha blockers, if you start, educate the patient about this orthostatic hypertension, that means that the patient try to stand up, he might end up with kind of faintishness, maybe collapse, and give it at the bedtime. But don't give alpha blockers, that we sometimes get the patient totally only on alpha blocker. There's no reason to start alpha blocker straight away. There are other medicine. We can give it as an add-on therapy if the other medicine are not controlling the blood pressure and not achieving the target. ACE inhibitors and receptor blockers are there, so maybe the indications we discussed. But if somebody comes with heart failure, post-MI, diabetes, or renal impairment, or past history of stroke, consider either ACE inhibitors or IRB blockers. This is a slide. Angiotensin 2, it plays a big role in the organ damage, and it's played a big role controlling the hypertension. So if you start ACE inhibitor or angiotensin 2 receptor blocker or renin inhibitor, it will reduce the angiotensin 2 level, and we should be able to get the required target. So if somebody comes with, if you are thinking about ACE inhibitor or thiazide, or how do you combine it? If somebody comes with maybe a diuretic, yes, there is a place, even as the monotherapy in stage 1 hypertension, that is 140 to 160 systolic, 90 to 100 diastolic range. And we start with lifestyle modification, diet, exercise, weight loss, and could start a thiazide diuretic, maybe HCT, maybe indapamide. Then, we could, then other thing is we can either start ACE inhibitor or receptor blocker. Especially if the patient is less than 60, we can straight away go for those things. And if the patient is more than 60, we can add with a calcium antagonist like verapamil diltiazem group or amlodipine, felodipine group, the peripheral acting ones. Alpha blockers usually to add-on therapy. Beta blockers, if there is an indication like past history of ischemic heart disease, maybe heart failure, then we think about, but better not to start as the initial therapy. Hypertension in the elderly, well, it's a very common area where you meet, and definitely there's a benefit of controlling the blood pressure, systolic and diastolic both, to achieve the target, that is less than 140/90, in systolic and diastolic hypertension and isolated systolic hypertension in both conditions. If it's more than 80 years, if the systolic blood pressure is more than 160, try to achieve systolic somewhere around 150. Don't try to reach less than 140, it may be too low. But if the patient is less than 80 years, we can think about less than 140 systolic. So frail elderly patient, we have to manage very carefully, and we get the complications when you are in the hospital practice, and the risk combination, hypotension, all these things we get as inpatient. A patient who was on 2 drugs coming with alpha blocker. Yesterday I had a patient had a fall in the night, fracture neck of the femur, and likewise, so it's maybe that we may be responsible, because we have to be very careful when we start medicine, and especially frail patients, elderly ones. Usually they live alone without their children, so we have to give a good education. Otherwise, that if somebody is managing kind of in a very difficult way, having a fall, ending up with a fracture hip, neck of femur, will completely change the lifestyle and the scenario of the patient. So elderly, we have to start with low doses and look for postural hypertension. Choice could be anything, maybe ACE inhibitor, ARB, thiazide, depending on your choice, and considering other comorbidities, because by 80s they have other problems like diabetes, maybe stroke, maybe bit of renal disease. In pregnancy, blood pressure target is less than 140. If somebody comes with high blood pressure in pregnancy, always we have to check the renal functions. And basically there are 4 categories in pregnancy. First category is the pre-existing hypertension. If the woman comes pregnant and the gestation is less than 20 years, means blood pressure during the first trimester means it's not gestational. It is not related to the pregnancy. It is a kind of a chronic hypertension, maybe undiagnosed. Then the gestational hypertension comes, the blood pressure, detect blood pressure, the booking visit, or maybe the first visit, the blood pressure is normal. After 20 weeks, the blood pressure is high, so that is the gestational hypertension. Third category is, after 20 weeks, we check the blood pressure and we check the urine. Urine albumin is positive. That means there belongs to the preeclampsia. And the last category, the worst category, is the high blood pressure, albuminuria, and maybe a fit to come to the category of eclampsia. Again, we start with non-pharmacological therapy, and we start with methyl-dopa, start with calcium antagonists like nifedipine, amlodipine, felodipine. Very rarely we have to consider beta blockers, and in an emergency we use IV labetalol or intravenous nitroprusside in the intensive care unit. Hydralazine still we use, but it is not the drug of choice now. And to improve the circulation, placental circulation, we have to start aspirin. White coat and the mass hypertension. White coat hypertension means somebody doesn't have blood pressure, then we check the blood pressure, it is high, which is very common. So white coat hypertension, no risk factors, and you do a accurate blood pressure monitoring, it is normal, you evaluate and you know which is the person. White coat hypertension is cardiovascular hypertension, don't release like that. Somebody comes, office blood pressure is high, you do a ambulatory blood pressure monitoring, it's normal. Then you can't say, you are okay, go home. Then ask about other risk factors, like smoking, alcohol, obesity, family history of ischemic heart disease. So you may have to think about treatment at that point. Then the other thing is mass hypertension. That means somebody comes to you and we check the blood pressure, it's normal. And they are the lifestyle and the things are a little odd. And then we have to ask for a ambulatory blood pressure, then we find that the blood pressure is high. Or when we check the blood pressure at the office it's normal, at home it's high, or when we check the blood pressure normal, checked by another doctor on different episodes it's high. Then we have to educate them then think about the lifestyle, maybe some treatment. Young adult, high blood pressure, no risk factors, and maybe white coat, then no treatment. But young adult with cardiovascular risk factors and other things, then again we have to try to achieve the target of blood pressure 149. CKD, maybe chronic kidney disease, with diabetes or non-diabetes. Again, we try to achieve the target of systolic less than 140, maybe 130. Basic the principles are same, and we tend to get ACE inhibitors, so ARBs can be combined with calcium channel blockers, but depending on our situation, we may have to go for the drug. And loop diuretics, if the patient is creatinine is 1.5 and a bit of peripheral edema, better to give a small dose of glutamine. Acute stroke, we don't control the blood pressure immediately, and we tend to be little modest in controlling the blood pressure. If somebody comes with a past history of stroke for a secondary prevention, we are thinking about diuretic plus ACE inhibitor or ARB. Recent MI, past MI, we are considering beta blockers, calcium channel blockers, maybe a limiting one for angina patients. And we may have to do a kind of a combination. And if the patient is having evidence of heart failure, then to release the diuretic, make it dry, then give a small dose of ACE inhibitor and uptitrate it to see whether the patient could tolerate it, then go for a beta blocker. Then think about heart failure, for drug-free system. And if atrial fibrillation with high blood pressure, control the blood pressure with ACE inhibitor or inhibitor receptor blocker. And atrial fibrillation with heart failure, then we think about beta blockers. And I put that slide purposely, and they discuss this as hypertension, atherosclerosis, and peripheral vascular disease, and erectile dysfunction, which is commonly encountered. Atherosclerosis, that is a peripheral vascular disease, and hypertension, prior peripheral vasodilating calcium channel blocker, like nifedipine and that kind of thing, maybe a ACE inhibitor or receptor blocker, like valsartan, camisartan, group. Then, if somebody comes with peripheral vascular disease, then we are a bit panic about the beta blockers. But they say the more important thing is to control the blood pressure. And honestly, there are lots of other groups medicine we can avoid beta blocker and control the blood pressure. But if the beta blockers in peripheral vascular disease, there's no great lots of studies to say it's controlled. But we caution there are other groups of medicine to control the blood pressure. Erectile dysfunction, you know that it's very common among the hypertensive. So think about most of the time the lifestyle, medication and anxiety, and try to avoid the beta blockers. But we can give calcium channel blockers, that the vasodilator type ones, and angiotensin ACE inhibitors or receptor blockers, or vasodilating type of beta blockers. And other thing that phosphodiesterase inhibitor, sildenafil group, they use very commonly when they have a lupus. Then that can be given in the patient with people with hypertension. People need phosphodiesterase inhibitor anyway, the kind of an age where they have hypertension, diabetes, and all kinds of things. But we have educated them not to take nitrate simultaneously. Resistant hypertension means 3 hypertensive drugs simultaneously. Then see why this is happening. Whether the poor compliance, what's the lifestyle, other drugs, NSAID, sleep apnea, whether there's any kind of organ damage, maybe polycystic disease. And if the patient has evidence of malignant hypertension is very high blood pressure, ischemic damage to the eye or kidney or heart. And then we have to think about stroke medicine, maybe that controlling the blood pressure with IV drugs. Hypertension emergency means systolic blood pressure more than 180 and diastolic more than 120 with some kind of progressive organ damage, maybe a patient confused, drowsy, and LVF and renal failure, that kind of thing. In that situation, not otherwise, if it's just 180, 120 without symptoms, we don't have to panic, but without impending progressive organ damage, we have to admit and treat them aggressively. Perioperative management of hypertension is If somebody is on beta blockers, we can continue. And if somebody is going to the surgery, we should not add diuretic or AC inhibitors because during the surgery there may be a amount of fluid limitation. And the most important thing is our experience is that when somebody comes for the surgery, anxiety and the pain is the cause for hypertension, high blood pressure, so we don't have to panic about it. We have to have then renal vascular hypertension, the renal artery stenosis, maybe a young person, fibromuscular hyperplasia, or in an elderly, could be the atherosclerosis. We can do angioplasty and stenting. Cushing's and pheochromocytoma, they are not that uncommon. Primary aldosteronism, then if somebody comes with high blood pressure and hypokalemia, we have to think about hyperaldosteronism and investigate. Basically, surgery is the treatment and medical management is with spironolactone. Cushing's syndrome, yes, and the surgery, proprietary surgery is the surgical treatment. Pheochromocytoma, again, the proper surgery is the surgical treatment, and we have to treat them with alpha blocker. So why this is the most important part, why the poor adherence to the medicine, why people are not controlling the blood pressure. Maybe lack of understanding. What we have explained, they might have not grasped. Dementia, senility, they can't remember things. Maybe a side effect of medicine. We give an ifedapine or amlodipine, like edema, they just throw it away. And because he's not aware, we haven't given a kind of a prior warning about it. Lack of discharge plan. When we discharge the patient from the hospital, we give 1 2 weeks medicine. They think as if for a cough and cold, 2 weeks medicine is enough. Now we don't have to continue the medicine. So that is happening very common. Cost. So we have to think everything. There's a budget for everything. So we have to think about the cost. Then maybe lack of symptoms. That the way when the headache is less, they get rid of the medicine. Complex treatment regimes. So better to give a kind of a once a day medicine given a choice than 3 times a medicine. And poor mobility. Maybe that that patient may not be able to come to the pharmacy or the practice or little or no support system. So how do you improve the adherence? The most important thing is that we have to talk to our patient and why, explain the condition, why this high blood pressure, and why the treatment is important, and the kind of compliance. And so patient should be a partner in the process of treatment. It's not like those days, that somebody comes and we give a treatment and our duty is over. This is my prescription, go and swallow this tablet. Nowadays it's different. And treating a patient is like an agreement. Somebody comes to us and he in Western part of the world, they say it's a customer comes and he comes with his problem. And we come to a diagnosis and we give the solution. Then we give the kind of a suggestion. So two parties come to an agreement, whether we like or not, it's like helping. So they come with a problem, we go through the situation, and we give the solution. So 2 parties come to an agreement, so regarding the plan. And so providing a clear written and oral instructions, and it should come, and it's very important in your practice. And I know that you all are doing a great service, but I'm just going through the list. And tailor the regime to patient lifestyle. Sometimes the patient can't take a kind of a lunchtime dose. No point giving a lunchtime medicine. Definitely guaranteed he's not going to swallow it. And look, approach patient. How are they going to take medicine? Their attitude. And in the family practice, it is the kind of one of the key pillars. And patient care, the family and their friends, and ways to simplify the regimes. And the refill dates, when are you going to refill it, how they are coming to them. Then practical, the disease management program, it's basically with the family. And periodic review. I know that most of the doctors in the family practice, they have a kind of a good recorded system, and maybe audit what's going on. And shared or group medical appointment, maybe a patient with diabetes, as a group give a kind of appointment and discuss the problems. And always we have to support the medication, and we see whether there's any barriers. Thank you.
Right. Good evening to all of you. And first of all, I'd like to thank the CPD committee of College of GPs for giving this opportunity for me to become a resource person in this session. Actually, I think probably by now you all know the guidelines, so my task will be very easy. So I'll be basically touching on, I'll be, giving a introduction, plus then I'll be taking you through a few clinical scenarios, and I'll give you some take-home messages. And in the meantime, if necessary, I will ask our specialist resource person to intervene. Right, now as you all know, hypertension literally means high pressure, and it can be systemic, pulmonary and interportal circulations. But often it is synonymously used with systemic arterial hypertension. Now, as you all know, definition of hypertension is persistently raised blood pressure 140-90 millimeters mercury or higher. Now, majority of them are, 95% of them are essential hypertension, which has no known etiology, and the remainder are secondary hypertension, where the cause is determined. Now, these are the few causes that is depicted in these pictures. Now, these are the secondary causes of hypertension. Right, now hypertension, in hypertension, screening is a priority because it is very, very common. And the second thing, it is asymptomatic. And the most bad thing about it is that it gives devastating complications. So GP has a big role as the first contact care in screening the people and identify hypertension and treat early. Now, blood pressure is normally distributed in population, and although we have given these cutoff values, there is no natural cutoff point. So we don't know where it can damage our organ systems. Now, what research says is, if each increase of 2 millimeter rise in systolic blood pressure, there is 7% increased risk of mortality from ischemic heart disease and 10% increased risk of mortality from stroke. And in younger people, of course, we see diastolic pressures are high. You know, in elderly people, what we see is more systolic hypertension, where you see more 180 millimeters mercury like blood pressure, where you will have to control the systolic blood pressure. Now, this is the latest classification according to the 2013 European guidelines. The hypertension, I think probably you know all about this by now. Now, the most important thing in family medicine as a family practitioner is now you should treat the patient with hypertension and not the hypertensive patient. And you should consider the patient who is in a community and who has a lot of physical, social and psychological problems, and you should give the care as curative and preventive, and you should give a personalized care to the patient. And the other important thing is the continuity of care is very, very important, which is lacking nowadays. And the patient carries a prescription and buys his antihypertensive from a pharmacy, and he doesn't know when to stop, what to continue, and what to stop. And sometimes even they don't know why he or she is taking this medicine. And the other important thing is always maintain medical records, which is also a lacking thing nowadays. Right. Now, this is the first clinical scenario that I'd like to discuss with you. Actually, this was a 50-year-old lady who presented to a GP requesting to check his blood pressure. Now, normally what happens is you check the blood pressure and send that person off. But now here, this GP was asking why she came. Then she came out with the story saying that she consulted a GP 1 month back, and her blood pressure was 140/90. And immediately she was started on ifilipine SR 20 milligram twice daily. Then further inquiry revealed that she never had hypertension in the past, and she was not sure why she was taking drugs and how long to continue drugs. So she stopped the medicine 2 weeks ago and decided to recheck her blood pressure to see whether it is cured. And On inquiry, she has no other comorbidities, no increased risk of cardiovascular disease, and she is not on long-term drugs. There was no evidence of target organ damage, and the blood pressure that was recorded that day was 130/80. And so the GP thought that he will repeat another blood pressure reading in 1 week's time, which was 130/70. So probably now the initial reading, which was 140/90, probably may have been wrong, or either probably that may have been due to some other reason. So probably this patient has no persistently high blood pressure. Now we should go to the medical student days now back, because now it's very important to accurately measure blood pressure. Now here, these are the guidelines given by the British Hypertensive Society, where a patient, when it sits in front of you, when you measure the blood pressure, he or she should be seated at least 5 minutes, relaxed, not moving or speaking. Now what happens most of the time is we check the blood pressure in a hurry, in a flash, 1 minute the patient is out. Now both feet on the floor, not crossed, no caffeine, no smoking within 30 minutes. And arm at the level of heart, no constricting clothes. Place the correct cuff and center of the bladder or the brachial artery. And the bladder should encircle at least 80%, not more than 100%. And you should inflate about 30 millimeters mercury. When radial pulse disappears, you should start deflating 2 millimeters mercury per second. Now, the other important thing is the validation of the sphygmomanometer that you are using. Ideally speaking, it should be serviced every 6 months, but at least in our country, if you service it annually, that would be better. And if you are using aneroid or digital meters, it should be validated more frequently. And in diagnosing hypertension, now at the onset, you should measure the blood pressure in both arms. And if the difference between arms is more than 20 millimeters mercury, repeat the blood pressure in say about 2-3 minutes. And if it remains more than 20, the subsequent measurements in the arm which is higher should be done. And if you are maintaining medical records, you should maintain the recording that saying that this arm is the thing that I am going to measure the blood pressure in the next visit of this patient. Now, in diagnosing hypertension, if blood pressure is more than 140/90 or more than that, take a second measurement. If substantially different, take a third measurement and record the lower of the last two measurements. And as Dr. Priyankara said, now these ambulatory blood pressure measurements and home-based blood pressure measurements plays a big role in diagnosis, especially in white coat hypertension and mass hypertension. Now, during waiting for the diagnosis, now you are not in a hurry, you will not start on medicine, because this is going to, the patient should take this lifelong sometimes. So look for the target organ damage, and cardiovascular disease assessment should be done. And these are the investigations that you should do, and plus you look at the fundi. Now, when starting treatment after diagnosis, of course, you should explore the ideas, concerns, and expectations of the patient, because it's very, very important, because everything depends, the compliance depends on the patient's ideas, concerns, and expectations. And always explain and reassure. And you should build up a good, strong doctor-patient relationship. And always you should negotiate the management. You can't force any management on the patient. And you should give a simple, affordable regimen, as Dr. Priyankara said, and give clear, concise instructions. Right. Now I'll go through the second clinical scenario. Now this is a 30-year-old lady who presented with headache, requesting to check blood pressure again. Now this patient, 2 weeks ago, her blood pressure was checked by a GP, and blood pressure was recorded as 144/94 millimeters mercury. And she was started on losartan, potassium 25 milligram Mani. And further inquiry revealed that she is on OCP since last 2 months, as actually she used IUCD for some time, and they didn't like it, so the partners decided to start on OCP. And further inquiry revealed that the patient is on aceclofenac sodium 100 milligram on and off for 3 weeks for a shoulder pain. And the blood pressure measured today was 142, 92 millimeters mercury. Now, on further inquiry, there was no cardiovascular risk and no target organ damage noted. And she took only losartan potassium every other day, fearing that, about the side effects of it. And she was further worried about a future stroke because she has a relation who has had a stroke because of poorly controlled blood pressure. So how are you going to manage this patient at this juncture? Now this is what is called drug-induced hypertension. Now, food constituents and chemicals can increase blood pressure, and especially the most studied is the sodium chloride. And the other drugs that lead to high blood pressures can be due to the intrinsic pressure effect or interfering with the cardiovascular control. Now, these are the common drugs. I don't know whether you can see clearly. Now, these are the common drugs that lead to high blood pressures, like sympathomimetic agents, NSAIDs, COX-B inhibitors, corticosteroids, CNS stimulants, estrogens, and some dietary supplements, and some antidepressants, and immunosuppressive drugs. So now here, the treatment here was probably to take a proper history and find out what was causing her hypertension and remove the offending agent. Actually, in fact, we removed the two drugs and the patient's blood pressure became normal in 3 weeks, right? But here now the problem is now you should keep in mind this may not be due to drugs alone. So you should have a good eye on the patient and you should monitor the blood pressure at least every 6 months. Now, the third clinical scenario was a 58-year-old gentleman who requested to check blood pressure again, and this patient was followed up by a cardiologist and was on telmisartan 80 mg MANE and clothalidone 25 mg MANE and was on amlodipine 5 mg twice daily. And this patient was very compliant on drugs, and blood pressure reading today, clinic reading was 180/100. And after 5 minutes, the repeat was 180/100 again. And this patient was fortunate enough to, he could afford a home blood pressure monitor. So we were able to monitor his blood pressure at home. It revealed the same values. And he never had any history of drugs inducing hypertension, and there was no target organ damage. And now here, what we see is a drug-resistant hypertension. Now here, what happens is now the patient is on maximum doses of 3 drugs, out of which one must be a diuretic, which gives the full dose. So now here this patient is on 3 drugs, but the blood pressure is not under control. And even say if the patient is on 4 drugs, if the blood pressure is under control, that is also considered as drug-resistant hypertension. Now these are the contributing factors. Certain races like say Asians, they have drug-resistant hypertension. And as Dr. Priyankara said, excessive salt intake and improper use of medication, especially over-the-counter drugs like say NSAIDs and other medicine that can lead to high blood pressures. Plus, it is very common in geriatric population. And 2 other things that lead to drug-resistant hypertension are sleep apnea syndrome and obesity. And with optimum treatment, 3 to 5% of general population has drug-resistant hypertension, and 20% of hypertensive population has drug-resistant hypertension. Here the treatment options are limited. You can try new combinations, but research doesn't reveal they are very successful. And you should advise to avoid, and you should identify the things that are contributing to this drug-resistant hypertension and avoid them. And here a specialist referral is needed. So now, probably now new technologies are also coming into picture. Now there are new device-based advances in drug-resistant hypertension. It is under research still. Now this baroreflex sensitization and renal sympathetic denervation probably will be one treatments that will be available in future. I think probably Dr. Priyankara will be able to give us a probably idea about it. And in drug-resistant hypertension, of course, GP can be a good manager who would coordinate with the specialist and other resources in managing this condition. The fourth clinical scenario that I'd like to discuss today is about a 52-year-old gentleman who is a diagnosed hypertension presents today to check his blood pressure. Now, his blood pressure today is 200 and 124, and repeat in 2 minutes it is the same. And he doesn't complain anything, he is asymptomatic. He admits defaulting treatment for last 3 weeks. And he was on enalapril 5 milligram twice daily and ifetroxim 20 milligram twice daily. There was no evidence of target organ damage, no additional cardiovascular risk. Now here, what is the diagnosis? How will you manage this patient? Now here, we should clarify two terms. One is hypertensive urgency. The other thing is hypertensive emergency. Now, when the blood pressure is more than 180, 120, hypertensive emergency is defined as evidence, high blood pressure, severe hypertension with evidence of acute organ, target organ damage. So this sort of a patient, of course, needs IV antihypertensives and need to be admitted urgently. And in hypertensive urgency, where no evidence of acute end organ damage, where severe hypertension is probably may be managed, can be managed in the GP setting. Now, the management of hypertensive urgency, here you should assess whether there is target organ damage or not, then identify whether there is cardiovascular risk factors are available, then measure the blood pressure in both arms and look for causes like non-adherence and diet, and do a thorough physical examination and do certain investigations to exclude this target organ damage. And here oral drug will be the first line, and you can use nifedipine, captopril, labetalol as first line drugs. Now even it makes sense to start on the same long-term drugs that the patient was on if the patient has stopped the medicine on his own. So hypertensive urgency is frequently related to non-adherence. And here you can relieve even the patient in 1 to 2 weeks without any problem, if the patient has no target organ damage or any cardiovascular risk. Now here there are problems now lowering the blood pressure within hours or to gradually lower the blood pressure in weeks. Now in urgency, of course, if no immediate risk of target organ damage, you can reduce the blood pressure gradually. No data proves acute reduction better than gradual. Right. So these are the 4 clinical scenarios that I wanted to discuss today. And these are the few take-home messages that I would like to give you, share with you. Now first thing is, confirm the diagnosis before starting treatment, because you should not be in a hurry if it is stage 1, stage 2 hypertension, because you don't have to start the treatment immediately. And exclude secondary causes which can be sorted out before starting treatment, because now remember that this patient is going to take this drug lifelong, so it is not an easy task. And GP has a big role detecting drug-resistant hypertension and appropriate referral and becoming the manager in coordinating the management of drug-resistant hypertension. And hypertensive emergency needs urgent admission, and hypertensive urgency may be managed in GP setup. And treat the patient who has hypertension, not the hypertensive patient. And continuity of care is very vital, and always maintain medical records. Right. Thank you. If you have any questions, queries, I think probably Dr. Priyankar and myself will be happy to answer.
I think I would like to emphasize, as you are with the kind of a family practice and close relationship with the patients and their families, one thing is, that in this country, at any given time, 500,000 people are pregnant. So we screen them from the onset of pregnancy until delivery. And if they are having diabetes and hypertension during the pregnancy, we treat them. And now after the delivery, we release them to the society. Right? And this is the category that getting diabetes during the pregnancy And hypertension during the pregnancy is the category. At some point in their life, they get the diabetes and hypertension again. So, but in our system, we treat them and they come to the hospital, they deliver, and they go home, and there's no proper follow-up. But when they come to your practice, if they have a diabetes or hypertension during the pregnancy, please keep eye on them. Because any given time, 500,000 are pregnant, and we screen them and we catch them and we release them. So, you know that from the family physicians, I think there's a big role to have a kind of a keep eye on them, because otherwise they might come with kind of complications of diabetic, maybe complications of hypertension and things like that. Answer to your question, the clopidogrel is overused. Yeah? And starting clopidogrel, when I was in UK during my postgraduate training, they said it is non-ST elevation MI 9 months and stent 2 years. Now then they said stent 5 years. Well, the thing is, reason is many people, they don't have guts or the studies to decide when to stop clopidogrel. And when it's a favorite drug among the cardiologists and the neurosurgeons, because the most of the cases neurosurgeons encounter related to cerebral bleeding, mostly related to clopidogrel. And it is a deadly drug for the surgeons. They won't touch. You know that we get lots of patients, maybe more than 8 years, come in with the fracture, neck of femur, keep in the hospital with the traction for additional 7 days because of the clopidogrel business. So keep eye on them and see whether they are unnecessarily on clopidogrel, whether it's really need. And if somebody is on clopidogrel, have a dialogue with their cardiologist. So how long you are going to continue, and whether it's really necessary. And it is not a magic drug, you know, that most of the time, I think we see lots of disadvantage of clopidogrel and advantage. So it's, I think, so we know there's a problem, but you know, it's not a very patient friendly medicine. Answers to his questions, I think we went through the scenario. It's like if you are doing the contract between the doctor and the patient, these questions should not arise. You know, that maybe that we are busy and the patient may be busy, maybe both are busy. So, but at some point we have to change our system to a proper practice. Yeah. Because medicine is a kind of a paradigm shift now. Things are advancing very fast, whether it's government sector or private sector, and patients are aware. They go through the internet and they go through the side effects, not like those days. So, you know, so we have to change our practice to improve the quality of care. Well, clopidogrel, the one indication is non-ST elevation MI for 9 months. It's solid in reason. Then after a stent, up to 5 years, there's a solid reason. Beyond 5 years, nobody gives an answer. You know, I go to this European Society of Cardiology meeting regularly. They discuss it, and they stop the discussion with a question mark. So maybe that obviously companies are not doing a trial to stop medicine. You know, they do a trial to continue the medicine, and maybe that there may be not volunteers to spend money to see whether we could stop clopidogrel. So that's what my feeling. You know, that all these studies are kind of you know, there's a kind of financial marketing backup. So all the studies are to continue medicine and not to stop the medicine. So it's our duty whether to see what the effects like, especially if somebody is in kind of, you know, in a risky age, maybe 70s and 80s, then think about it. Don't give it unnecessarily. And on the other hand, if we start by a cardiologist, the patient will not stop that. But if you write to the cardiologist, then, you know, kind of having a dialogue, patient is aware of the side effects, that will be a little bit safe practice. All three parties know that it is not a good drug. Especially people with aortic regurgitation in elderly could complain. But a very wide pulse pressure, more than 30. That's if you try to low, so these are, when we say control the blood pressure less than 140 is a kind of a very blanket statement. Then if you have that kind of wide pulse pressure, we have to see why. Whether the patient has got aortic regurgitation or some kind of underlying pathology. Then we have to be little cautious, and then cautious about the medicine even. Sometimes still there may be a possibility of, if the diastole is 60, little tricky, still you could try with a small dose and see how the patient goes, to control the blood pressure and the symptoms wise. But again, it has to be done very, very carefully. Most of the time it comes with a bit of aortic regurgitation.
What type of drugs that you think?
Again, by that age, they have some other comorbidities definitely. So if not, if it is more than 80, then a calcium channel blocker is a safe drug. Less than 80, maybe a little young side, then the ACE inhibitor or ARB is a safe drug. And if you are starting thiazide diuretic, keep eye on sodium. It might come down. Thiazide also, it's a possibility. Beta blockers, we don't start straight away unless there is another reason to start. Maybe ischemic heart disease or post-MI, something like that. Basically, mainly thiazide diuretics, calcium channel blockers, diltiazem verapamil group and the nifedipine group, and the ACE inhibitors and ARPs. So those are the major actors in the scene. Others come to the result.
When a patient can sustain systolic blood pressure, say a 70-year-old one,
Sorry?
and having 180 by 115 or 120, how much it should be lowered?
Yeah.
And
if the patient is less than 80, we have to target the systolic 140. If the patient is more than 80, systolic should be 150, but we don't have to do it overnight.
No, I understand that the patients with sustained systolic pressure, where we were told during our time, don't treat, and now the CVAs have increased threefold. And I want to know how much and how soon the pressure has to be dropped to 140.
Well, it's like this: if the patient is asymptomatic, if it is if it is 160, 170 range, that means 30 above the cutoff point, then straight away better to go for a medication in addition to the lifestyle. Always we have to educate about the lifestyle. That's the basics. No? And that range, I think we should start with the medicine, and you can see the patient in a week's time, see what's going on. But 170 systolic is not something that we can advise lifestyle alone, and we have to start the medicine at that point.
Thank you.